Good evening, everyone, and thank you for joining us for What's New in Hip and Knee Replacement. My name is Cindy Leonard. I'm Business Development Manager at Saint Alexius with Ascension Illinois. And joining me is Kristen Collins, Vice President for Strategy and Business Development. It's truly a privilege to bring conversations like this to our community. Whether you're just beginning to explore your options or seriously considering surgery, tonight's webinar is designed to give you the information and confidence you need to make informed decisions about your joint health. Before we turn things over to our speakers, I would like to quickly review a few items. First, this webinar is being recorded. By participating, you consent to the recording and its potential use for replay, promotional, and educational purposes. If you choose to ask questions or make comments, your name and likeness may be included in the recording. It is my pleasure to introduce our speakers. Tonight, we're joined by two board-certified orthopedic surgeons who specialize in joint replacement and revisions. Dr. Michael Harvey brings advanced expertise in hip and knee replacement, including complex revisions with a strong focus on innovative techniques and improved patient outcomes. Dr. Frank Bohnenkamp is a fellowship-trained specialist known for his personalized approach as well as minimally invasive and robotic-assisted hip and knee procedures. Together, they are dedicated to helping patients experience less pain, regain mobility, and return more quickly to the moments that matter most. Please join me in welcoming Dr. Harvey and Dr. Bohnenkamp.
Thank you.
All right, everybody. Thank you for spending this Wednesday evening with us. I know there's other things going on and taking some time away from family and work and other obligations to listen to us and hear us talk about what we're really passionate about. We appreciate that, and we really hope you learn something and gain something from this. As Cindy mentioned, feel free to take notes and jot down some questions and type in some questions that pop up during our talk, and we'll do the best that we can at the end of the presentation to answer as many questions as we can. So just jumping in, what do we do as hip and knee reconstruction specialists? So after the nice introduction, you guys heard that Dr. Bohnenkamp and I obviously went to medical school. We did a 5-year orthopedic surgery residency, and then we took an extra year of training after that to really hone in and focus and specialize on hip and knee replacement surgery. So we love what we do. In our opinion, there's nothing that's more rewarding than helping people in our community get back to the activities that they enjoy without pain. And we really do try to live every day dedicated to improving the care that we give and provide our patients and improving our outcomes as well. We do really take pride in keeping up to date with the current practices and current technologies that allow us to improve care and outcomes. And both Dr. Bohnenkamp and myself really do that on a daily basis. All right, so tonight's talk, really what we want to do is help familiarize you guys with the current best practices and technologies that Dr. Bohnenkamp and I truly believe in and we use for our hip and knee replacements. And a lot really has changed, even from when I started practice 5 years ago. I've changed my practice pretty drastically, and I know Dr. Bohnenkamp has too. And that's going to continue to happen. I mean, innovation happens so quick in the medical field, and I think even more so in the orthopedic field with what we do. So this is a brief overview of how the talk's going to get broken down tonight. So you can see we're going to talk about kind of same day or outpatient total joint replacement, which basically means you get your hip or knee replaced and you're going home within 24 hours or that very same day. We're going to talk about our rapid recovery protocols that help you get up and moving and recovering as quick as possible. We'll talk about the surgical techniques that we use for our hip and knee replacements. We'll talk about the technologies that we're implementing today. And at the end of the day, teamwork is what really gets the job done. And we'll go into that a little bit at the end as well. So we'll start talking about the same day and outpatient total joint replacement. So this is just a little background, a little bit of history of kind of where we started and where we're at now and where we're going. So from 2012 to 2015, there was about a 47%, so almost a 50% increase in elective outpatient total joints. So, that's total joints that are being done and patients are going home the very same day versus surgery done in the hospital and patients staying in the hospital overnight. So it's a pretty big jump. It's projected to increase 77% by next year. Well, the amount of inpatient total joints is only increasing about 3%. And it was projected, this was a study done a few years ago, that by the end of this year, that greater than 50% of our primary total hip and total knee replacements were going to be done in an ambulatory surgery center. So you're not even talking about at the hospital and going home. This is actually at an ambulatory surgery center separate from the hospital, where there's really no option to stay overnight. Everybody's getting up and moving right away and going home that very same day. So from that same study, just a graphic here to really show how dramatically the swing has been from 2016. You can see 85% of these total joints were being done in the hospital and patients staying overnight, with only 15% outpatient. Whereas this year, like I said, the projection is going to be greater than 50% of these hip and knee replacements. We're getting you up, we're getting you moving, we're getting you home the very same day, which is pretty exciting.
I think those numbers that he was projecting are accurate, probably surpass it because like he's saying during the COVID-19 pandemic, I mean, it really pushed everything towards an outpatient setting.
Yeah, definitely. So,
Agree.
that segues pretty perfectly. So, kind of how did this happen? Why did this happen? So, one of the things was in 2014, CMS rolled out a bundled payment for care improvement plan. For people who don't know what that is, basically for a hip or a knee replacement, the insurance company would kind of pay out a lump sum for that entire period of care that kind of started with the surgery and encompassed a global period after surgery of 90 days. So anything that happened in that period of time that cost money was taken away or taken out of that lump sum. So the facilities, the providers would then get less money. They'd be compensated less for their work. So this really kind of made us as surgeons want to be more cost effective, more efficient. So to decrease our cost of care, but also to really minimize our complications, because any type of complication that would require a return to the emergency room, a prolonged stay in a rehabilitation center, another surgery, anything that would happen within that 90-day period, we would get compensated less for our work. So I think this really did kind of spur in the surgeons really an initiative to try and administer really good cost effective care, but really the emphasis is on really quality care, to minimize complications. And at the end of the day, that's really what matters. And like Dr. Bohnenkamp mentioned, I think the COVID-19 pandemic really supported this and pushed surgeons who might not have otherwise been comfortable with outpatient surgery or taking that leap to outpatient surgery. I think it really kind of helped. With COVID-19, I'm sure everybody remembers the hospital systems were inundated. There weren't enough hospital beds to take care of all these sick patients. Some of the operating rooms at the hospitals were being turned into intensive care units. The anesthesia staff was kind of pulled out of the operating room and where they were taking care of the COVID patients on the ward. A lot of the equipment that we use for surgery to intubate patients for surgery if necessary, a lot of that equipment was being used to treat COVID patients. So a lot of hospitals actually completely shut down elective inpatient surgery, just due to lack of room, lack of resources, lack of staff. So if surgeons wanted to continue to practice and take care of patients with debilitating hip or knee pain, you really had to shift and do the surgeries on an outpatient basis if you wanted to continue to work and continue to take care of patients. So I think that caused a pivot in a lot of surgeons to kind of head in the outpatient direction.
Yeah, I mean,
and there's a
you're right. Like the silver lining is that it really forced our hand to like optimize care and get people out of the hospital setting into an outpatient setting, recover quickly from total knees and hip replacements. I agree.
Yeah, and there's plenty of literature, plenty of studies out there that show that patients that are done in the hospital and that have to stay in the hospital, it can lead to prolonged recovery, lower patient satisfaction. If you're sitting in the hospital for too long, you can get infections from that, and it really does incur an increased cost to do the surgeries in the hospital. This is just kind of a busy slide. I apologize, but just demonstrating that there's probably at least a 30% median cost savings for outpatient surgery versus having to stay in the hospital. And you can see that graphic on the right shows you really the discrepancy with the ward kind of the nursing, the cost associated with staying overnight and paying for people to kind of be in the hospital and really not even be taken care of you because you're kind of sleeping most of the night, or at least trying to. So shifting from the hospital to outpatient is truly a really cost effective measure. And as I mentioned, it's a safety measure too, which I'll talk about more in a couple slides. So it's pretty impressive. So in 2010, the average length of stay for patients undergoing a primary hip or knee replacement was 3 to 4 days in the hospital. So almost a full business week in the hospital. I remember, and I think you probably remember, Dr. Bohnenkamp, when we were in our training, we'd have patients roll into the preoperative area and have a full suitcase packed for their stay, for their total joint. And that's not something you see anymore. The present length of stay is 24 hours or less, and that's just going to continue to go down, I think. We've increased our efficiencies as surgeons, so we can do more surgeries and get the surgeries done earlier in the day. So that also helps facilitate patients going home. We're not finishing the surgeries super late, so it gives time patients to recover from the anesthesia and get up and start moving and working with physical therapy and go home. I think the technologies have helped us increase our efficiency as well. There's also been a demographic shift over time. So, as our implants are getting better, they're lasting longer, our surgical techniques are better. We're starting to do these surgeries on younger and younger patients who don't want to waste the most active years of their life or healthiest years of their life in pain. They want to get back to being active, participating in sports and other recreational activities. So we are doing these surgeries on younger patients, and the younger patients, it is easier to get them home. And we also implement rapid recovery protocols, which we will go more in depth later in the talk. So one of the questions that we get oftentimes in the clinic when we're indicating a patient for surgery or going to schedule surgery is, I like the idea of not having to stay in the hospital, but some patients are a little bit nervous, understandably so, because at the end of the day, when you think about getting a full hip or knee replacement, it's not a small Band-Aid surgery, it's a surgery. So the question is it safe? Because at the end of the day, that's really what we care about the most when we're talking about the setting of surgery and sending you home the day of surgery. So here's just a study that I brought up done out of Rush, where they looked at 170,000 total joint patients, primary hip and knee patients, and they compared the inpatients versus the 24-hour stay or outpatients, and there was no difference at all in patients having to get readmitted after going home or patients having to get repeat surgery for complications. And interestingly, in this study, the patients who were done in the hospital and stayed in the hospital actually had a higher complication rate. They mentioned that they control for kind of confounding variables in that study, but I tend to think that it's probably going to be the patients that are a little bit more high risk anyways that are going to be staying in the hospital. So I think that's probably slightly skewed. But what I really take from this study is that I don't think there's any increase in complication rate or decrease in safety for patients going home the very same day. Similar study, similar group, this time looking at patients that had a total knee replacement as an outpatient in the Medicare population. So they looked at 50,000 patients that were Medicare age that had total knee replacements. And once again, their complication rate for the short stay or going home was only 2%. And the inpatients who stayed in the hospital was 8%. So it's very safe. It's been proven to be safe if done correctly, properly by an experienced team and experienced surgeon. It can be done safely, very safely, going home the same day. So who's a candidate? We get that question all the time. So like I mentioned, safety is the most important thing. We wouldn't do this. We wouldn't advocate for it if it wasn't safe. So in general, healthier patients with a good support network at home are the best candidates for the surgery center. I'm not judging the 100-year-old nice looking lady lighting her birthday candles with a cigarette, but she wouldn't be first on my list to have surgery at the outpatient surgery center. And then patients that have non-complex problems, kind of your run-of-the-mill arthritis, not necessarily this, patient, you can see the x-rays there, on the right side of the slide that had multiple prior surgeries, has a lot of plates and screws and orthopedic hardware in there. That's a more complex surgery that Dr. Bohnenkamp and I would be performing in the hospital. And it's important to have mutual trust in the process. So I'm an advocate for outpatient surgery. I think it's great. I think it's safe. I think patients really benefit from it. But that being said, if I see you and there's really some fear and really don't want to go home after surgery, if you're not comfortable with it, it's not something that we force you to do. I really want the entire group, the patient, the family, everybody involved to be comfortable with it, to get it done. We also get asked, am I not a candidate? Who can you not perform these surgeries on at a surgery center? So, or as in an outpatient setting. So in general, patients over 90, we like to keep an eye on you overnight, at least one night, just to make sure that you recover from the anesthesia okay, and to make sure that we get you out of bed and moving okay with physical therapy. That's not strict. It's pretty amazing how many times I see patients that are right around that 90 mark that are physiologically a lot younger and healthy and active and still mowing the lawn and mobilizing pretty well. So I wouldn't say it's a strict cutoff, but that's kind of a pretty good threshold, I would say. Patients that really have poorly controlled chronic medical conditions, probably not the safest place to have their surgery in an ambulatory or outpatient setting. And then patients who have been on chronic pain medicines, have multiple allergies, or have had prior problems with anesthesia, we would tend to consider keeping them overnight in a hospital setting, just because we'd hate to do the surgery, everything goes well, you get discharged home, and then all of a sudden there's a problem that night and you got to come back to the hospital. That's just not convenient or pleasant for anybody.
I would add to that as well, patients with a poor support network, if they live alone, they don't have support at home, they definitely cannot go home the same day.
Agreed, definitely. So we went over there a little bit of the same day and outpatient total joint stuff. We'll segue into some of these rapid recovery protocols. So these recovery protocols are multifaceted, different kind of areas throughout the episode of care that we've really focused on to try and get you recovering quickly, get you up on your feet quickly. So the type of anesthetic that we use plays a role. So spinal anesthesia is how we perform most of these surgeries, and I'll go into detail on that in a little bit. We do give a regional anesthesia where we're numbing the nerves around the either hip or knee, depending on what surgery you're getting. That can provide some long-lasting pain relief, even after the surgery, really just blocking the sensory nerves that carry the pain signals, but not affecting the motor nerves, which move the joints to allow you to get up and start moving and walk and go home right away. We also use an injection at the time of surgery. We're injecting what's called a multimodal kind of joint cocktail around the tissues of the knee to help with pain control and inflammation and swelling. Dr. Bohnenkamp will talk to you a little bit later about the multimodal kind of oral pain control regimen that we use after surgery when you go home. And then just getting up, moving around, walking early, participating in therapy early, doing exercise early, that aids in the rapid recovery. Just going over the difference between the general anesthesia and the spinal anesthesia. So these are definitely the two main ways that these surgeries are done, two main anesthetic ways that the surgeries are performed. So I think we're all pretty familiar with the general, where you basically are completely knocked out. The anesthesiologist has to protect your airway by putting a breathing tube down your throat, and they have you on machinery to breathe for you throughout the surgery. It's a very rapid and reliable way to get anesthetized so that we can do our surgery, but it is associated with a lot of systemic side effects, as you can see down there. I'm not going to read them all off for you, but general anesthesia definitely associated with some unpleasant systemic side effects. And I'm sure, if you haven't, you've heard about somebody who's had a pretty adverse reaction to a general anesthetic. Spinal anesthesia, it's a little bit different than the epidural that people associate with childbirth. It's kind of a single shot of some numbing medicine, of a local anesthetic that we give to basically numb the body from the waist down, so that we can do the surgery without you feeling anything. The main benefit of that is you don't have to get that general anesthetic. So you're able to be breathing on your own the entire surgery. You wake up a little bit quicker. They don't have to put a breathing tube down your throat. It can help with some pain control after surgery. So in general, I think this is a very safe and effective way to do the surgery. And most patients really overall enjoy the experience of the spinal anesthetic. And, one of the questions I get a lot is, since you're not totally knocking me out with the general anesthesia, am I going to see what's going on or feel anything or hear anything? But that's not the case. So the anesthesiologist will still give you a sedating medicine so that you're basically asleep, but still breathing on your own. But you don't have any idea of what we're doing with the surgery. And you wake up in recovery and you're all done, regardless of the anesthetic you get. Just a quick study. I like to bring in some literature and kind of do things that are tried and true and proven to be safe and effective. This is basically what's called a systematic review, where they pooled a bunch of different studies. In this case, they looked at 94 separate studies, just looking at the perioperative outcomes and complication rates of patients that get the joint replacement surgery, either with the general or the spinal. And pretty shockingly, they made this blanket statement that you see kind of highlighted there, saying that considering all of the outcomes, the complication rates, uh, the neuraxial anesthesia, and that's their way of referring to the spinal anesthesia, is the preferred anesthesia technique that reduces the risk of most, but not all complications. So it really is a safe and effective way to get these surgeries done with that spinal anesthetic. We're going to talk a little bit about the kind of oral multimodal pain control. I'll turn it over to Dr. Bohnenkamp.
Yeah, thanks, Dr. Harvey. Basically, me and Dr. Harvey, like just reviewing, we work together continually on improving these preoperative, intraoperative, and postoperative pathways. So we're current with the literature, and we're always looking for ways to improve, especially early pain recovery. So we employ a multimodal pain control system, which includes preoperative and early postoperative medications, trying to limit narcotic usage among patients. So we usually use something like an anti-inflammatory, given their medical conditions. I mean, there's things we could tailor to the patient, but you want to treat the symptoms post-surgical. So you want to treat inflammatory response from the actual surgery. So we use something like a meloxicam or Advil, those kind of things, NSAIDs. We'll use something like a Lyrica or gabapentin, which will treat burning nerve, incisional pain, etc. Prior to this, however, we do regional nerve blocks prior to the spinal anesthesia, which is our preferred method of anesthesia. This really helps with post-surgical pain for at least the first 24 to 48 hours. We also include things like Tylenol, which is was tolerated very well by patients. An extra strength dose. You got to make sure they don't get stomach upset. We do blood thinners. We are current with the literature, so we don't do anything aggressive, which would lead to something like bleeding or hematoma after surgery. So we use things like aspirin, unless they're required to have things like Eliquis or higher anticoagulants. But we also, higher risk patients, will employ antibiotics. So we do multimodal pain relief, and we try to prevent issues from occurring. What's new is that in the United States, there's a big push to get away from narcotic pain medications, which I think is great. I mean, this has been a problem since, we were in training with orthopedic surgery. It's very painful. We're cutting bones. So patients, back in the day, we used to use large amounts of narcotics. This is a very North American, like an American thing that just got out of control, especially with the opioid epidemic. So there's a big push to get away from it. There's a new medication on the market called Jornavix, which we've been using, especially in our older patients. It's also known as Sutragine. It's a recently FDA-approved medication. It's first-in-class, non-opioid oral analgesic. It's for moderate to severe acute pain, including post-surgical pain. So this is what you use it for. But basically what it does is it selectively blocks a sodium channel in the peripheral pain sensing neurons. So what that means, the same sodium channel is minimally expressed in the brain. So if you get pain from a surgery, it blocks that channel from communicating with the central nervous system. But the benefit of this medication, it doesn't have the same side effects as an opioid pain medication. So there's no risk of respiratory depression, sedation, or addiction. And there's plenty of phase 3 or advanced trials showing that it is comparable relief to things like hydrocodone. Surgical techniques, Dr. Harvey and I, we do minimally invasive techniques. We basically, most of our cases for our hips are anterior approach, unless it requires something more complex like a hardware removal or revision. But some of those are anterior as well. But this is a benefit because we can minimize our incision. We could place it in a position of the hip where it heals well. We protect the soft tissues using different equipment, and it limits our dissection because we're going between the muscles. We're not cutting any muscles. So we have very delicate soft tissue handling. Or it makes it way more efficient, especially when everyone's trained and they know your steps, especially in the surgical or the outpatient surgery setting. And then in the hospitals, once everybody gets trained up to how we do this, we could actually limit our operative time, which is probably the most important to prevent post-surgical complications.
And if you look at that graphic down there on the bottom right, so that's that purple ring that you see there. That's one of the specialized retractors that Dr. Bohnenkamp and I both use for our hip replacements. It actually was designed as an intra-abdominal retractor for the general surgeons, but we saw that it could provide adequate retraction for our surgeries while minimizing trauma to the soft tissues around the incision, and even deep within the incision. It protects the tissues. So that's something else that we employ to really make sure we're protecting the soft tissues and limiting the amount of surgical insult or trauma to the tissues to decrease the amount of inflammation and swelling after surgery.
Exactly.
And Dr. Bohnenkamp mentioned the approaches that we use. He mentioned we both typically employ the direct anterior approach. The graphic there shows, in general, there's 3 classic ways to perform the hip replacement. There's a posterior approach, there's a lateral approach, and then there's the direct anterior approach that we employ. The blue arrow there coming from the backside down towards the hip joint, the posterior approach, you can see it goes through that large muscle group, the gluteus muscles, the butt muscles, kind of have to go through and split that big muscle group, and also take off some of the tendons on the backside of the hip in order to get down to the hip joint to do the surgery. So that definitely is a little bit more of an invasive type of surgery compared to that anterior approach. The lateral approach, that red arrow, in this depiction, it looks like it would be a fairly minimally invasive way to get down to the hip. But what you don't see is that when you access the hip from the lateral side, you have to cut through a major tendon called the abductor tendon that helps you stand, it helps you walk. And a lot of patients can develop a pretty significant limp that doesn't go away if you go through that approach. So that green arrow, the anterior approach that we use, like Dr. Bohnenkamp mentioned, it allows us to get down to the hip quickly and safely and not cut through or go through any muscles or any nerves or anything like that. Another thing that we do is we utilize a bikini incision. So that picture there on the right is a patient who has had a anterior hip replacement through a bikini incision, and you really can't even see her scar. I'll preface this by saying not everybody scars that well, but we found that when you make the incision in such a way that, when you're sitting or flexing the hip, it provides more of a compressive force on that incision rather than a tensile force, and it allows the incision to heal quicker and with less wound complications. Because people beginning out with the anterior hip replacements, one of the kind of main knocks on the approach is that it can be associated with an increase in wound complications. And you can attest to this too, Dr. Bohnenkamp. I think with adequate patient selection, good soft tissue handling, and the bikini incision, I think I don't really see too many wound complications. Definitely not increased compared to any other approach.
Correct.
Also, the way we do the surgery on an anterior table where you're laying flat, it allows us to get really good x-rays intraoperatively. So Dr. Bohnenkamp and I know exactly where we're positioning the implants, the exact size of the implants, and how we're putting the implants in when we're doing these hip replacements. And it allows us to use that computer navigation, which I think Dr. Bohnenkamp's going to talk to you a little bit about soon. And then the way we do our knee replacements, we do not use tourniquets. Back in the day, these surgeries would take hours, and patients would have a tourniquet compressing their thigh. You can see a patient here in that depiction that has bruising and swelling throughout the whole proximal thigh region where that tourniquet was on, and I think that delays recovery, can cause pain, can cause a limp, and it's really not pleasant. So doing the surgery without a tourniquet, I think, helps with that, and also allows us to control the bleeding at the time of surgery so that it doesn't bleed after surgery. The way that we do the surgeries now, we utilize something called a kinematic alignment of the knee replacement. So historically, a lot of surgeons would use a kind of cookie cutter type of alignment strategy called mechanical alignment, where the goal was to orient the knee joint line perpendicular to the straight up and down axis, or the weight bearing axis. That worked very well for most patients, but not every patient has their knee joint aligned flat with the ground. Some recent studies came up that showed there's probably at least 12 different orientations of the joint lines for different patients. So it would make sense to Dr. Bohnenkamp and I that if everybody's knee is different anatomically, why would we put a knee replacement in the same way in those patients? So we've kind of followed a technique now that allows us to place our knee replacement implants in such a way that is personalized, and it's kind of a true resurfacing of how each patient's knee was aligned prior to the development of arthritis. And we both have noticed kind of a quicker recovery with that technique, and the robotics being involved in that surgery allows us to do that even more accurately and more reproducibly. And Dr. Bohnenkamp will talk about that as well.
Yeah, thanks. So I'll kind of get into the technology part of it. So like he was saying, Dr. Harvey and I, we mostly do anterior hip replacements. So that being said, we use a special table and X-ray guided, like basically it's called fluoroscopic X-ray guided navigation. We use the VELYS hip navigation system. So because consistent component positioning and leg length restoration can be very challenging with a hip replacement. So this is a very simple, non-invasive, image-based navigation system designed to improve precision during anterior hip replacement. It's supported by multiple clinical studies. It uses real-time data, as you can see from the pictures that we're using, on cup position, so placement of the acetabular component in the socket, leg length, so we get the leg length perfectly aligned to basically their pre-arthritis their offset and their leg length. We use a one trial approach. So we get the parts put in, the trial implants before we put the final implants in. And we use the X-ray fluoroscopic guided system uses artificial intelligence assisted landmark recognition. So you don't need pins, you don't need any preoperative imaging, which is nice for the patient, and it's very efficient. So based on our preoperative templates that we do when we go into the surgery, when we use this system, we could really recreate the normal anatomic alignment of post-surgical total hip replacement patients. So we could really get them restored to where they used to be prior to the arthritis. So total knee replacements, there's, we're going to go into the technology a little bit, but there's been a long history in total knee replacements. In the early attempts were done in the 1950s and 60s. They basically focused on, from the pictures, like a hinge type replacement where they were linked in the middle. They did improve stability of the joint, but they did not replicate normal knee motion, and they loosened early and failed mechanically at the interfaces. So the major breakthrough actually occurred in the early 1970s with the total condylar knee system, which is basically gave birth to the sort of current technology. It matched the natural knee anatomy, and it wasn't linked in the middle. So they had longer durability. It allowed a controlled motion, sort of mimicking the knee replacement. But again, it was very primitive in design, and it would not match like every patient specifically. But by the 1980s and 90s, total knee replacements had become a very much reliable procedure, and they've continually refined implant materials, alignment principles, and surgical techniques. You know, over time to current, it's a better understanding of that. We've had a better understanding over the decades of knee biomechanics. It's led to anatomically shaped implants that preserve controlled motion of the knee while improving fixation and wear characteristics, improvements in the polyethylene, the plastic components of the knee, better metals. We improve metallurgy and cement techniques as well, because these parts are cemented into the knee replacements. It's led to increased implant longevity and reliability, which has been reproduced over the literature over the years. So more recently, advances have shifted towards improving precision and personalization of each knee replacement for each patient specifically. So modern knee replacements, they emphasize accurate alignment, soft tissue balance, and restoration of natural knee kinematics. So we're using current technologies such as computer navigation, robotic assistance, and patient-specific planning. This has really helped reduce variability between surgeons and improve reproducibility. As far as robotics, I'll kind of just touch on this briefly, but it's been around kind of since the early 2000s. It was developed in a response to the question and persistent challenge of variability in implant alignment and soft tissue balance. So, what is the alignment of every patient? Everyone's different. And then all their soft tissue around the knee, it's different amongst all the patients. So, the early 2000s, the first robotic systems came out. They were fully autonomous devices that focused mainly just on bone preparation, and you could only mimic like certain mechanical alignments. So, it still wasn't personalized. They were very costly, complex, bulky. They were difficult to integrate into like a normal practice. So, but by the early 2010s, with the computer technology, robotic technology evolved into a surgeon-controlled, kind of a semi-active system. So they had better control of the platforms, and they would combine preoperative imaging. Still required a lot of information to input into the system, but it did allow for some real-time feedback, and some surgeons were able to make more precise bone cuts, but they had full control of the procedure. So that was sort of the changing point in the early 2010s. So currently, today's robotic knee systems, we use the VELYS. I use the VELYS, so does Harvey. It emphasizes personalization of each patient. So what it does is it utilizes real-time data. So it's fast. It optimizes the patient's specific alignment. You could balance their soft tissues in real time. You can correct their deformities in real time, and you can plan the implant position for each patient specifically, including the size. It's moved beyond. So basically, robotics has moved beyond just regular mechanical alignment, like he was talking about, one size fits all, to restoring an actual normal knee function for each patient. So in the near future, it's exciting because advancements are continually occurring with artificial intelligence and data integration. So we have a lot of data on it. It's improving our workflow efficiency. So these technologies are dramatically increasing or reducing the variability among surgeons and shortening the learning curve so more people can learn it.
Yeah, I'll just echo the excitement that robotics and the advancement in knee replacement surgery with the robotics is pretty remarkable. So while you're in surgery, this technology basically allows us to create an extremely accurate 3D representation of your anatomy of your knee while you're on the table, and it lets us truly plan a personalized knee for each and every patient at the time of surgery, without having to input a bunch of data preoperatively. It's pretty amazing to have that feedback and to be able to be that accurate with implant placement based on our surgical plan and not have to be utilizing multiple surgical steps, multiple different cutting jigs or cutting guides that increase the length of surgery, increase the trauma of the tissues, and really aren't as accurate, in our opinion, as the robotic technology.
So, I mean, truly, it's like a fourth generation robotics. It's very user friendly. It's small. It's compact. And then in the near future, like I said, there with the AI technology, is basically what's going to happen is it's going to be a user interface where you don't no longer need pins and arrays. It's basically the robot's going to see what we're seeing, and it's going to automatically map out that patient specific alignment so that the robotic saw can place a knee perfectly in for that exact patient. And then there's a little video on this technology that we utilize at Saint Alexius.
When preparing for a knee replacement surgery, you may be interested in learning how advanced technology will be used in your procedure. DePuy Synthes, a leader in orthopedics, offers the VELYS robotic-assisted solution designed for digital precision in knee replacement to help you start moving again. Let's take a closer look at how the technology works. The system includes a robotic-assisted device, a high-speed camera, optical trackers, and data screens designed to help surgeons achieve the highest possible precision level. With the VELYS robotic-assisted solution, surgeons are in control during the entire procedure. The device does not move or operate on its own. Your surgeon will start the procedure by making an incision in your knee. Next, they attach trackers to your knee, which work with the camera to gain the information needed to perform your procedure. From this information, the surgeon creates a 3D model of your knee. Your surgeon will move your leg back and forth to test the function of your knee. This will help assess your full leg alignment and soft tissue tension. During your procedure, your surgeon continually gathers data related to your knee to help them perform a precise knee replacement surgery personalized to your specific anatomy. This process helps your surgeon optimize the outcome with the use of data that's unique to you. Designed for precision, this advanced technology can help your surgeon visualize and predict the stability of your knee joint, find a favorable implant fit, and perform a highly accurate knee restoration. To restore your knee, the surgeon guides the robotic device to remove the damaged bone and cartilage in your knee, making sure it matches the surgical plan. The technology software is used to verify your final alignment and balance. The implant components are placed, and your surgeon will check the range of motion. Then your surgeon will remove the trackers and close the incision site. After the surgery is complete, your care team will work with you on developing a post-surgery recovery plan. For more information, ask your surgeon how the VELYS robotic-assisted solution can help you start moving again.
Thought that was kind of a good little video to see what we actually do. That's the equipment that we use at St. Alexius to do the knee replacements. Now, in the last year, it's the same technology we're using for partial knee replacements as well with the new AI technology. So I just wanted to mention that. You can go to the next slide. So, with robotic knee replacements, there's some people, there is a learning curve to it for surgeons. I mean, we're highly trained. We embrace technology and the advantages that it proposes, but in my practice, and Dr. Harvey would also probably say similar. I've been in practice for 12 years, started doing robotic knee replacements about 4 years ago with this system. I've noticed that, for example, patients at 2 weeks look like they're 6 weeks. Not all the time, but a lot of times way more than they used to. And so I think the early recovery is better. Less narcotic pain relief or pain refills needed, less pain swelling. There's less clicking, feels less mechanical to patients. So I would say, based on the literature, what do we know about robotic knee replacements? It has shown to clearly improve surgical accuracy and alignment consistency. Short-term data does show similar with emerging evidence of better early satisfaction and quality of life, especially at 1 year in patients less than 75 years of age. So there is some advantage to the early recovery for sure. Long-term data compared to manual knees, it's still yet to be determined, but we don't have enough data yet in the long term to say this consistently, but I suspect that it will be better. And we can't say cost and efficiency depends on the high volume and speed of the surgeon and how much it actually would save. But long term, we don't know quite yet. But early, I think Dr. Harvey would agree that patients seem to be a lot happier earlier, which makes for their recovery, especially in the early phase after a major surgery. You don't want to be down. You don't want to be down that long. You want to get back on your feet with the least amount of pain and problems. Plus, it makes our job as surgeons in the clinic. We don't have to, when patients are feeling better with less pain and issues, it makes our lives a lot easier as well as theirs. So I think it's a big benefit to this technology. And this is not done without our teamwork. I have 2 physician assistants. Dr. Harvey has 1, probably 2 soon. But we have a lot of people that work on our behalf, including the Saint Alexius staff has been very supportive. We have great nurses, care teams, physical therapists. I mean, everybody's involved. We run a very tight ship. Everything's very seamless. If there's any issues, we always work around it, but everything is run very smoothly. And I think our patients are very satisfied with that.
Yeah, definitely. We're only a piece of this puzzle. It really takes every single person involved to, be successful with these surgeries and take really good care of our patients.
Some pictures of our family.
So I think that concludes our presentation. Cindy, Kristen, are we going to try and open it up for some questions if we had a little time?
We do have a couple of questions actually that came through, and I think some of them, Dr. Harvey and Dr. Bohnenkamp, you've addressed already, but maybe you can just give us a little bit of a refresher. Dr. Harvey, this one's for you. Which is preferred, outpatient versus hospital stay for surgery? I know you mentioned this a little bit earlier with some of your research. Do you have any preference as it relates to outpatient or hospital stay?
Definitely. If you're a good candidate as a patient, and we work through that together, and I really take pride in being able to determine who is a good candidate, safe patient for outpatient surgery. I'm definitely an advocate for doing the surgery and going home. I provided some slides that demonstrated the safety of outpatient surgery and going home. The patient satisfaction is also a lot higher with going home. I think a lot of us just feel more comfortable and can recover better and rest a little easier at home versus staying in the hospital overnight. And they don't really do too much for you anyways that first night, specifically if you're going to be in the hospital. So definitely, if you're a candidate, I'm a proponent of doing the surgery and getting you home. With that being said, there are patients that I do think benefit and their surgery is more appropriately done in the hospital. But overarchingly, going home the day of surgery is preferred and I think beneficial for everyone.
And so, Dr. Harvey, follow-up question there. If outpatient, what movements or exercises are needed in the first 24 to 48 hours?
Yeah, so really for the first even couple of weeks, but definitely within the first 24, 48 hours, there's a balance between us wanting to get you up and move, but not doing too much to the point where your body's not able to heal, not able to resolve the swelling and the inflammation caused from surgery. So the main focus early on is kind of getting up, moving the muscles, moving the knee or hip, walking. But really, there's a lot of resting involved in the initial postoperative phase as well. But kind of gentle motion of the knee, not getting stiff, and then getting up and kind of walking and working on the gait, working on the balance is probably most important early on.
Perfect. And then Dr. Bohnenkamp, a question for you.
Sure.
Are there any supplements recommended for the month before or after surgery?
I mean, we always tell patients, if they tolerate it, you want like a higher protein diet. You want to make sure you have enough protein, albumin to heal wounds, for example. We do recommend like a vitamin C, zinc, or vitamin D. This is all for like skin wound healing. If you're worried about kind of delayed problems, but other than that, and multivitamin's good, but we try not to do supplement like I guess over the counter supplements such as things like turmeric or other unusual supplements, because some of those can have a blood thinning effect which can cause problems.
Perfect. Thank you for that. Okay, last question. And this could be for both of you. So, Dr. Bohnenkamp, I'll ask for your thoughts first. There's potential risks and complications, obviously, as you've both demonstrated with the surgery. How does a person who's weighing kind of the benefits of the surgery, having the surgery versus the complications, how does one weigh those differences?
Well, I mean, I think the complication, depending on what complications you're discussing, but um, it's pretty rare for anything major, such as infection or fracture or something like that. Wound healing complications can occur in certain people with poor nutrition or smokers, etc. But if you're healthy, I mean, a complication is pretty rare, probably less than a percentage on anything major. Um, so it's a quality of life function. It's, if you're having pain every day and you can't do the activities you like to do, um, that could lead to more problems and, not doing the surgery, but it's a personal decision.
Okay, perfect. All right. Actually, we do have one more question in the chat if we have a minute. So, this was put in the chat. My upper and lower leg bones do not match up as my former knock knee wasn't fixed when I had that hip replaced in 2009. And I'm highly allergic to propofol and have a pain pump implant. Is it likely that your robotic can fix my multi-issue knee problem with a replacement?
Yeah, I think, there's obviously layers to that question. And for Dr. Bohnenkamp and I to really give an educated professional opinion on if we'd be able to get that fixed for you, we'd have to see you in the office and evaluate, examine you, get some imaging. But to kind of pinpoint your question about the deformity of the knee bones not matching up, it sounds like there might be what's called a valgus deformity or the knock knee. And that really is one of the benefits of the robotic system is that while you're there on the table getting your surgery, the 3D model that's reconstructed of your knee, that robotic technology tells us exactly what your alignment is and how much kind of deformity that you have in your knee, whether that be a bow leg or a knock knee. And we are able to correct that really however much we want to, however much is appropriate to a very precise degree with the robotic technology. So we definitely can, and we do straighten out the limbs that are deformed with the corrective knee replacement surgery.
Yeah. If you have a deformity through the knee, knock knee or bow-legged, it's definitely correctable with robotic knee surgery.
Awesome. Thank you both. All right.
Sure.
That's it for me for questions. Cindy, I'll turn things back over to you to sum things up.
Okay. Well, this is the picture of the state of the art Ascension Saint Alexius Center for Advanced Joint Replacement. And as you can see, it's built for your comfort. It's dedicated for hip and knee replacement surgery center and office robotic assisted technology, along with private rooms and more.
Yeah, it's a fantastic place. It's dedicated staff that we are very efficient with total joint replacements. It's not in the main hospital area, so all the patients there undergoing orthopedic procedures, so it's very optimized towards the patients.
Okay, I just want to say thank you to Dr. Bohnenkamp and Dr. Harvey for your time in answering and sharing such valuable information. We really appreciated it. On behalf of Ascension Illinois and St. Alexis, we want to thank everyone who joined us this evening. We truly appreciate you taking the time to learn more about getting a fresh start for your joints. We're here to support you on your journey. So if you're ready to take the next steps, we invite you to schedule a consultation and explore your joint replacement options by calling 847-755-8885.